Hello, everyone, and welcome. We're going to give folks a few minutes to get in before we get started. Thank you. Just letting folks know we're going to give it another minute or so while folks are still joining, and then we'll get started. All right. I see numbers slowing down a little bit. I'm sure people will continue to join in, but we're a couple of minutes after the hour, so we'll go ahead and get started. Good afternoon, and welcome to the HL7 Da Vinci Community Roundtable. Today's session is federal updates on TEFCA, testing, and the payer provider 10 by 10 coalition, and Da Vinci's take on HTI-2. So we are happy to have you today for our jam-packed session. My name is Denise St. Clair, and it is my great pleasure to moderate today's community roundtable. I will remind all of you that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. It is great to have you at today's webinar. We are really excited to have our two special guests joining us today from the Assistant Secretary for Technology Policy, ASTP, formerly known as the Office of the National Coordinator for Health Information Technology, ONC. So today we will hear from Mark Nee, the Division Director of the Interoperability Division in the Office of Policy at ASTP, and Chris Muir, the Division Director, Network and Scalability Division in the Office of Standards Certification and Analysis at ASTP. Chris will say a few words at the beginning of the session, and then Mark will be highlighting why the Trusted Exchange Framework and Common Agreement, TEFCA, is important, and sharing some recent updates to the program, including implementation, some long-term plans, education and outreach, and some items on building trust under TEFCA. In the second segment of ASTP's presentation, Chris is going to discuss testing and adoption efforts covering TEFCA's Health Level 7 FHIR, Fast Healthcare Interoperability Resource Roadmap, and ASTP's new TEFCA Payer Provider 10 by 10 Coalition. So we're very excited to hear more about that. And Chris is going to provide an overview of the 10 by 10 and discuss why providers and payers should participate, and also discuss some resources available and the interplay between the 10 by 10 and the work we are doing in Da Vinci. So after this presentation, we will obviously have time for questions, and we'll be very interested in getting those from you. But then I'm going to report out a bit on behalf of the Da Vinci Project Management Organization on some themes and perspectives from our Da Vinci members on the health data technology and interoperability, patient engagement, information sharing, and public health interoperability HTI-2 proposed rule. So that will be the last presentation of the day. So we're gonna, like I said, have time for questions after each presentation. Encourage you to use the question function in Zoom throughout the event today. So as you have a question, please go ahead and type that in so we can review your questions with our guests at the end of their presentation. So with that, let's go ahead and dive right in. Just a little bit of housekeeping though. We will post a recording of today's webinar and the slides on the Da Vinci video presentations page on Confluence. And Da Vinci's communication lead, Leslie Amoros, who we are incredibly thankful for all of her amazing work for making today happen, will be posting the links in the chat box, as you can see, to assist you in locating that page and any of the other resources that you may find of interest that we note today. Again, please be sure to use the question feature to submit questions because we've limited the chat feature so that you can get these key details from Leslie in the chat, and that you can also then download the chat at the end of the presentation if you want to hang on to all these great links and resources that Leslie's making available to you. We have also muted lines to aid our recording quality. So finally, we really appreciate if you would, at the end of the session today, do fill out the survey. That is wonderful information and helpful for us. On our last bit of housekeeping here, and hopefully you can still hear me as my earbuds die at a wonderful moment. The community roundtable, so you know, our next session is going to be October 23rd. And do note that there will not be a community roundtable in September because of the work group meeting in Atlanta that is happening sort of at that time. So we will see you in Atlanta in September, and then we'll be back on the community roundtable in October. And we do have some other upcoming events that we are tracking too, and we encourage you all to check out. So we're looking at the WEDI National Conference coming up in October, the Civitas Network annual meeting happening in Detroit in October, the annual meeting for ASTP in December in Washington in December, and then obviously the HL7 work group meeting plus and Connect-a-thon will be September in Atlanta. So we look forward to seeing you all there. But with that said, I think we can officially pivot to our main event, which are federal updates on TEFCA testing and the Payer Provider 10x10 Coalition. So, Chris, I will pass it to you.
Great, thank you very much. I wanted to share with you that ASTP will be taking a more active role in the Da Vinci FHIR Accelerator going forward. You know, ever since Da Vinci began, ASTP has been following Da Vinci's work with great interest, I will say. We had people attending meetings and we would meet with Da Vinci leaders and staff from time to time, but we never really had I guess I would call it a formal role. But more recently, ASTP has decided to become more active in Da Vinci. This is being driven by how important it is to get payer and provider interoperability enabled and adopted to help meet our healthcare goals. And additionally, and relatedly, we know that this is important for meeting CMS's interoperability objectives. And of course, CMS is an important partner of ours. And also, TEFCA is underway, and we have treatment, healthcare operations, and payment exchange purposes that we are supporting. Therefore, we're going to be taking a more active role. And Avinash Shanbag, the Principal Executive Director for the Office of Standards, Certification, and Analysis, an office within ASTP, obviously, and will become a member of the steering committee. And Matt Ron, the Director of ASTP's Standards Division, will be a member of the operating committee. And I just want to say that ASTP is very pleased to be more directly engaged with Da Vinci and working shoulder to shoulder, you might say, with the leadership and all of its members to advance payer and provider interoperability. So we would like to say thank you very much to the Da Vinci team for allowing us to engage with you in this manner. And that concludes my remarks on this topic. And I will now turn it over to Mark, who will give us a TEFCA overview. Mark?
All right. Well, thanks, Chris, and thank you for having us here today. So as was mentioned before, my name is Mark Nee. I'm the Director of the Interoperability Division in the Office of Policy at ONC, or ASTP ONC. It's okay if you guys call us ONC still. I think everyone knows. So I'm excited to be here to talk about TEFCA and let you know what's been going on. Next slide, please. So I think most of you all on the call are pretty familiar with, the basics about TEFCA. So I'll go through that pretty quickly and really focus more on what's new within the TEFCA framework and what's next. So as many of you probably know, TEFCA was derived from the language in the 21st Century Cures Act that said that the national coordinator shall convene appropriate public and private stakeholders to develop or support a trust exchange framework for trust policies and practices, and for a common agreement for exchange between health information networks. So based on that language, we got working in, I guess, late 2016 and have been working since on trying to develop the policy, technical, and legal framework for nationwide interoperability through TEFCA Exchange. Next slide, please. All right, so, big picture, what's TEFCA trying to do? It's trying to simplify health data exchange. And, what this slide is talking about is that there's been a lot of great successes over the years, and TEFCA really wants to build on those successes from national networks, state networks, local networks. The problem is that we saw as, the government, is that there were gaps that still remained. And as you can see, this unfinished business is that there are gaps related to public health, less well-resourced providers like rural and behavioral health and LTPAC. Payers as well have struggled to get interoperability going, social services, and research. And a lot of times people are a little hesitant to have the federal government supporting, big initiatives like this in the way that we are, but we've actually heard quite positive feedback that, federal government involvement is really required here to spur the evolution of nationwide network interoperability and to strike the right balance between allowing, competition in the industry, but also to make sure that there's uniformity and everyone's playing by the same rules and that apply to everyone in a uniform way. Next slide, please. All right, so TEFCA has 3 goals, or big picture goals. 1, to establish a universal policy and technical floor for nationwide interoperability. 2, to simplify connectivity for organizations to securely exchange information to improve patient care, enhance the welfare of populations, and generate healthcare value. And 3, to enable individuals to gather their healthcare information. Next slide. So this is the umbrella slide. It's pretty much been the same over the years. We've updated it a little bit, particularly with the new ASTP logo on the left. But the general structure is still the same. So ASTP ONC creates the overarching policies for TEFCA, and we work closely with our colleagues who we contract, the RCE, the Recognized Coordinating Entity, which is the Sequoia project, to implement those policies, to update the common agreement and draft the common agreement, update SOPs and draft SOPs, and to work on application review and onboarding and designation, and overall compliance of QHINs in the network on an ongoing basis. Then you have these QHINs, who are the Qualified Health Information Networks, these super nodes, as we say colloquially. They're big organizations that are capable of supporting nationwide exchange at scale. Currently, there are 7 QHINs, and I'll get into a future slide who those are, and we have more coming through the pipe. So, very exciting there, and it's a really diverse group of QHINs as well, which I think supports the competitive nature that we want to see in TEFCA to provide choice and value to everyone who's participating. And then as you look down at the green circles, those are participants. So those are members of each QHIN. And then sub-participants, you can be, a sub-participant of a participant and still connect to the QHIN and benefit from TEFCA Exchange. So really one of the key pieces about TEFCA is that wherever you are on this picture, as long as you're signing an agreement that includes the terms of participation, which are the required flow down provisions from the common agreement, which is signed between the RCE and each QHIN, there's this base level of trust, and that kind of gets you in the door to query for information on the network, as well as to share information across networks in a seamless way. Next slide, please. All right, so one of the big value adds for TEFCA, you know, if you're wondering how is TEFCA any different than what's out there already, is that, you know, primarily in a lot of the exchanges that exist, treatment is the primary focus, which makes sense because, you know, it's the foundation for, I think, all health information exchange. And TEFCA treats it that way, but we also are expanding on treatment to include payment, healthcare operations, public health, government benefits determination, and individual access services as the 6 exchange purposes that have been authorized under the common agreement. We are working to roll out standard operating procedures, which are documents that the RCE and ONC work on together to add some color to the requirements in the common agreement and provide operational details for implementing each of the exchange purposes. We heard from industry that it wouldn't make sense to require responses for all of the 6 exchange purposes off the bat because that's just not where folks are, which makes a lot of sense. So right now, treatment and individual access services require a response. And we just released the SOPs for healthcare operations and public health, which is huge. And we're working on payment and government benefits determination as well. And as you can see, exchange purpose number 7, Mickey Tripathi, our national coordinator, has said repeatedly that, you know, publicly that really the 7th exchange purpose will be research. We still need to figure out the parameters of how it will be framed, but we understand the significant value that enabling exchange for research purposes would bring to the market. You know, we'd have to consider things like standardized consent, data de-identification, and data requirements and standards. But we're starting to work through all those different pieces. Next slide, please. All right, I think maybe is there another piece to this slide? If you, yep, there we go. Look at those pictures. Not the most flattering picture of me in the front row on the bottom picture, but yeah, so a lot of exciting stuff going on with TEFCA. So this is an event that we held at HHS's Humphrey Building on December 12th, 2023, which was the Common Agreement signing event, signifying that TEFCA had its first QHINs and would be live. And there you see Secretary Becerra, who has been a great champion of TEFCA, and really we've been working hand in glove with Secretary Becerra and DepSec Palm to make sure that you know, we're doing everything we can to make sure to realize the promise of TEFCA on a nationwide scale. Next slide, please. All right, and here you can see that the approved and designated QHINs, right now there are 7: eHealth Exchange, Epic, Nexus, Health Gorilla, Kanza, MedAllies, Commonwealth, and No2. They're now live, meaning that actual exchange is able to happen across these QHINs. You know, like I said, this is really a great starting point for QHINs because if you look at the diversity of these organizations, you have so many of the leaders in the health IT interoperability space, like eHealth Exchange and Commonwealth. And then you have others who, you know, Epic, obviously a huge EHR vendor who created an arm just for TEFCA to exchange. And then you have, for instance, like different models like Kanza, which is a Kansas-based HIE, and No2, and MedAllies, and Health Gorilla. They all bring different perspectives and different services to TEFCA. So we really think that we are providing, you know, what everyone will want. You know, there's different options for each person and each organization, and they just have to, you know, do some research and look into each QHIN and they'll find one that fits. Next slide, please. And also worth mentioning that there are a couple more QHINs that are going through the onboarding and testing processes right now. Or they're not QHINs, excuse me, applicant QHINs who are going through onboarding and testing. Okay, so new and updated documents. What have we been doing since TEFCA went live? A couple of things. I think Chris probably will talk more about FHIR, but we have a version 2 of the FHIR roadmap, which is a document that describes how we're going to incrementally increase the use of FHIR-based exchange on TEFCA. It was released on December 11th, 2023, and it updates the previous roadmap by providing more details and guidance for the future of FHIR in TEFCA. We also released Common Agreement version 2. So Common Agreement is the agreement, like I said, that's signed between the recognized coordinating entity and each QHIN that establishes the same rules of the road, the same requirements for policy and technical aspects of TEFCA, that everyone agrees that they're doing the same stuff. And for things like privacy and security, it's important that there's this alignment across the network. It was published on May 1st, 2024, and includes enhancements and updates to support FHIR-based transactions. And I think on a future slide, I'll get into some of the more granular details of what was changed from version 1.1, which was the previous version, to 2.0. And then also new and updated SOPs are being released in the coming months and on a rolling basis. We just had a release just a few weeks ago of 5 SOPs, a couple updated ones, and then, like I mentioned, healthcare operations and public health, which were new. So that was huge, momentum, I think, for realizing, or at least getting closer to implementing all of the different exchange purposes that have been authorized under TEFCA. Next slide, please. All right, so here are some release notes for Common Agreement version 2. So the implementation date of the Common Agreement version 2 is 60 days following publication in the Federal Register, which is June 30th, 2024. So that's already happened. It's been implemented. After the implementation date, the Common Agreement effective date is the date the RCE and signatory execute the Common Agreement, signatory being the QHIN. Some of the details in the Common Agreement, we moved to the standard operating procedures, and that includes the governing approach, cooperation, RCE directory service, TEFCA exchange activities, individual access services, and security. And basically the overall approach that we're trying to take here is that we understood that the Common Agreement was a very dense agreement that had a lot of legal language, and we tried to streamline it as much as possible, understanding that the SOPs are incorporated into the Common Agreement and are really an extension of the Common Agreement. We're trying to make it so that, thinking long term, the Common Agreement can be closer to being evergreen, and some of the more granular details can be included in SOPs, which be updated on an ongoing basis as needed. Here on the right-hand side, some new stuff that's included in Common Agreement version 2, the addition of required encryption for individually identifiable information in transit and at rest for all non-HIPAA entities, applies some requirements that are already in place for IS providers to also be applicable to non-HIPAA entities. One of the big things about TEFCA as far as privacy and security that I want to highlight is that, we leverage HIPAA, the security rule, as well as the privacy rule, most of it, as much as we could, that aligned with what we were doing. But then we also extended it to apply to non-HIPAA entities, because if you look at TEFCA Exchange, there's going to be organizations like apps that are going to be participating in individual access services and other exchange. And we want to make sure, again, talking about playing by the same rules, that the HIPAA regulations applied, not only to covered entities and business associates, but also to non-HIPAA entities as well, which we think is really important. And in some ways, like is noted here, we went above HIPAA to make sure that the protections for privacy and security in TEFCA are really, really strong. The next one on the right-hand side is the new static participant, sub-participant terms of participation. So again, this is essentially the flow down provisions that were included previously within the common agreement, and now this is an appendix at the end of the common agreement. And this is a plug and play document that cannot be changed, and it needs to be included in any agreement between a QHIN and a participant, or participant and sub-participant, to be connected to TEFCA Exchange. And again, that creates that base level of trust that's needed for everyone to know that when they are participating in TEFCA Exchange, it's being done the right way, and the information is being securely transferred, and there's privacy applied that is necessary for everyone involved. Next, the definition of TEFCA Exchange governs all transactions identified by a unique TEFCA Exchange purpose code. So this is more into the technical aspects, but in order to make TEFCA Exchange functional, we've shifted to this approach where there's different codes that are specific to TEFCA, and we can build that out over time. And then it's a pretty flexible structure that allows for the building of blocks over time to create more and more exchange codes. Next slide, please. All right, so what's next? And a lot going on. I mean, it's a busy time, which is great for our office with regard to TEFCA. We want to advance additional exchange purposes and use cases, including early demonstrations. One that I really want to highlight here is we've been working really closely with our colleagues at CDC on the public health exchange purpose, and the CDC-led public health early demonstration for two distinct use cases: electronic case reporting and query for case investigation follow-up, went live on July 1st, 2024. So that's extremely exciting. We're also working with CDC to try to identify a community that may be able to be used as essentially a testing ground for TEFCA Exchange. So that's an exciting development that we're working on. And we're also engaging, with our federal partners, which I think is, on the bottom bullet as well. But CMS, SSA, VA, we have regular meetings to make sure that our federal partners are understanding how they can benefit from TEFCA and become a part of TEFCA Exchange in a meaningful way for all of their constituents. We want to also work constantly on expanding TEFCA participation. The only way that TEFCA will be successful is if, people trust it and see the value in it to their organization, and then they connect. And, I think we were on a call one time where one of the QHINs said, really, success for TEFCA would be having every provider in the country connected. Obviously, that's a lofty goal, but I mean, that's the idea. And I think you're seeing a lot of really positive momentum in industry to shift and coalesce behind TEFCA. I'm not sure if folks saw, but Care Quality put out, which is a leading health information network, but they said that they are going to work to align their policies and framework to work with the TEFCA Exchange, which is huge. And Epic said that I believe all of their customers, they're trying to get transitioned over to TEFCA Exchange by the end of 2025. So I think we're at a great starting point, and there's really a great deal of momentum behind TEFCA participation in Exchange right now. Another key piece here is education and outreach. One thing we've seen is that even though, as I've worked on TEFCA for 4 or 5 years now, I understand it, and it seems like I'm like, everyone understands it, but then you go out to different communities, and there's just a lot of questions, different levels of understanding of what TEFCA is. How do I become a part of it? What value would it bring to me and my organization? Why would I want to invest in TEFCA? So those are the types of questions that we're trying to answer for folks. We're developing a bunch of resources that will be available pretty soon, including some videos and data sheets. And we're also just trying to get out there and engage as much as possible, because we all in my office believe in the value of TEFCA, but we need to make sure that everyone across the country sees that it can benefit everyone. Everyone goes to a doctor, everyone's a patient, and everyone deserves to have a more robust medical record at their disposal, or available to them and to their providers, to make sure that they're getting the best care possible. And, that would improve care outcomes as well. Another thing we're trying to do is continue to further adoption of FHIR-based exchange. we started out with document-based exchange as the base level for TEFCA exchange, but in version 2 of the common agreement, we've shifted significantly to encourage FHIR-based exchange. Both are available still through TEFCA exchange, but we've heard loud and clear that FHIR is what a lot of folks want to see implemented as soon as possible to really push interoperability forward and make sure that point-to-point transactions are able to happen in a seamless manner on TEFCA. And so it's going to be, again, like everything, putting together some building blocks to piece by piece and get to, a greater FHIR adoption, but we're making great progress there. And again, I mentioned working with our federal partners and emphasizing that along with the collaboration we've been doing with our federal partners, we're also working to, as much as possible, incorporate TEFCA into federal programs so that there is an added benefit to those who want to participate in TEFCA. Next slide, please. All right, well, great. I think I did pretty good on time. So this is where I pass it over to Chris.
Yeah, thank you very much, Mark. Hi, everyone. Again, my name is Chris, and I'm the director for the Networks and Scalability Division. And among other things, my division supports the technical aspects of TEFCA. And I was asked to give a presentation about the inclusion of FHIR within TEFCA and some of the early testing and adoption efforts. And I believe most of you are aware that TEFCA is currently operating using SOAP-based IHE profiles between QHINs. And this slide reflects the exchange modalities currently offered within TEFCA, including, as it states here, patient discovery, document query and response, and message delivery. And TEFCA initially, and still uses the IHE profiles because that is basically what is being used in the market today. However, we are currently in the process of offering FHIR API exchange as Mark pointed out in his remarks. Can we go to the next slide? Because FHIR APIs are the future for health information exchange, again, Mark touched on that a little bit. And because of that, we wanted to message ONC's and the RC's interest in including FHIR in our TEFCA plans. And so we developed the FHIR roadmap, and Mark mentioned that we released the second version of the roadmap late last year in December. And as the slide shows, we see FHIR being included in TEFCA in 4 stages. And the first stage was the initial launch of TEFCA with document-based exchange, and entities were able and allowed to exchange FHIR payloads using the IHE infrastructure with some out-of-band coordination. And then in stage 2, the stage we're currently in, we released, as Mark again mentioned, the Common Agreement version 2, the QHIN technical framework version 2, and then also the facilitated FHIR implementation SOP. And they all contain either policies or technical specifications to enable point-to-point FHIR exchange and using some QHIN facilitation for it to happen more efficiently. And I will talk about that in a moment, but a couple of other things I wanted to mention on this one is because we anticipate TEFCA participants and sub-participants going live with facilitated FHIR exchange during this calendar year. And I also wanted to point out that supporting facilitated FHIR is required for QHINs at this stage, but it is optional for participants and sub-participants. And then in stage 3, which we anticipate being in approximately calendar year 2026, we will provide specifications for enabling QHIN to QHIN exchange. So it's QHIN to QHIN using FHIR API exchange. And that capability will enable use cases such as using FHIR calls between QHINs to do things like patient discovery and FHIR endpoint retrieval. And those are just a couple examples. And then in stage 4, FHIR API exchange will be available following the same exchange patterns, we call it end-to-end, that the IHE profiles provide today. And so the data gets routed through the network between exchange partners using FHIR. And just to be clear, these stages are not mutually exclusive, but they are in addition to each other. So we're just layering on capabilities and not replacing them. So can we go on to the next slide, please? So I mentioned in stage 2, the stage we're currently in, we are enabling facilitated FHIR, and I wanted to just quickly give an example on how that works. So if I'm a healthcare provider wanting to find data about a specific patient and I want to exchange using FHIR, I would first go through my QHIN to determine who has information on the patient that I'm interested in. And then through my QHIN, patient discovery would take place using the IHE profiles. And once it is determined who has information on my patient, I would also be able to retrieve their FHIR endpoints using a directory that's connected to the RCE directory, which contains those endpoints. And then I would reach out to the specific endpoint that's used by that specific data holder, and I would be able to register, authenticate, and then obtain authorization using OAuth-based processes. Then I would be able to query that FHIR server and then retrieve FHIR resources on the specific patient. Can we go to the next slide? So the QTF, among other things, specifies what QHINs must do to enable facilitated FHIR for their participants and sub-participants. Additional requirements related to facilitated FHIR exchange, including requirements for participants and sub-participants, are in the facilitated FHIR implementation of SOP, which this slide reflects. So one of the major things that the SOP covers is the optionality we are initially providing for registration, authentication, and authorization. And these 3 options are as reflected on the slide. The HL7 FAST UDAP security for scalable registration, authentication, authorization IG. This IG is often referred to as SARA, and so that's what I'll refer to it going forward. And next is the Smart Application Launch Framework IG with the smart backend services. But in addition to those two IGs, we also allow other authentication and authorization frameworks that adheres to the requirements of the QTF. And as an example of that, some payers and or providers are using mutual TLS to securely connect to each other while doing FHIR API exchange. That's just an example of that. But in any regards, the long-term goal is to eventually require everyone to use the first option, SARA, because it allows for dynamic registration at scale by leveraging the trusted community and the TEFCA certificates, instead of having people use the traditional OAuth patterns of manually registering with each endpoint to attain access. That approach really doesn't scale for an environment like TEFCA. Because most EHRs don't support SARA, we are providing these options until January 1, 2026 to allow the EHR industry to catch up in supporting SARA. And another thing I wanted to point out is that TEFCA largely aligns with ONC and CMS regulations. We want to leverage the standards and functionalities that are currently in certified products. So for example, we will require the use of FHIR R4 with US Core 3.1.1, which are in regulation. But we also will allow our newer versions of US Core. I also want to mention that participants and sub-participants will have the, as I mentioned before, the option of using SMART for registration, authentication, authorization, which is in certified products. And I also think it's important to note that subsequent versions of the QTF and FHIR SOPs will be updated to align with standards and other requirements based on the latest HHS regulations. And on the slide, there are a couple of other things I wanted to point out. FHIR servers should and not must also support additional IGs, including the bulk data access IG. Also MHD, which is an IHE profile that supports FHIR API exchange and a IHE SOAP-based environment. But additionally, and really importantly, and especially for this group, likely, we strongly encourage the option of implementing the Vinci Payer data exchange or the PDEX IG, as well as the Vinci Clinical Data Exchange IG or the CDEX IG. And finally, if there are any conversions of data, it must be documented using the FHIR provenance resource. Next slide, please. So another important thing to note is that prior to January 1, 2026, we are initially allowing those that are doing FHIR API exchange to determine their own exchange partners. This will allow exchange partners to get experience in making FHIR API exchange work in TEFCA. It'll give them that experience to make sure they work out all the kinks and they're comfortable with it. And of course, because of the optionality, there will, of necessity, be some pre-coordination that will have to take place among the exchange partners. And, but however, beginning in 2026, all those doing FHIR API exchange should anticipate exchanging with all others using SARA. So let's see, next slide, please. So I'm going to switch gears now and talk a little bit about FHIR testing and also about the TEFCA Payer Provider 10x10 coalition. And I'll start off by explaining that any testing and early implementations of FHIR is going to be coordinated and analyzed by the TEFCA FHIR Implementation Advisory Group. Among other things, this advisory group will be coordinating with the different people who are implementing and testing, and they'll be analyzing and really making recommendations to the TEFCA governance in order to identify future related requirements. So based on the testing and based on the early implementations, that advisory group we'll be analyzing that, making recommendations to the TEFCA governance, and then that will be the driver for any future updates with FHIR specifications. So among the first of these early implementation efforts is the TEFCA Payer Provider 10x10 Coalition. We often simply call it 10x10 or the 10x10 project. You'll probably hear me using all these terms interchangeably. And as the name suggests, ONC is trying to recruit 10 payers and 10 providers to become early adopters of TEFCA. The project is meant to establish the feasibility of payers participating in TEFCA. And also, the project will aim at launching early examples of exchange between payers and providers. Additionally, we want to identify and address challenges in order to inform future policies and or technical approaches related to payer-provider exchange. But of course, a primary focus of the 10x10 is for payers and for providers to implement FHIR-based exchange. And they will be leveraging existing infrastructure such as the G10 criteria for certified APIs. And of course, that largely applies to the providers and their EHRs. And also they will be following the FHIR capabilities as described in the QTF and the facilitated FHIR SOP. Next slide, please. Because the 10x10 project is still pretty new and is just getting off the ground, this slide reflects our current thinking about scope, but we may have to adjust our plans as we have more input from payers and providers. But the idea is that we want 10x10 participants to be early adopters of TEFCA and join the QHIN by the end of calendar year 2024. And also we want them to become early adopters of FHIR APIs and supporting payer-provider exchange use cases. They would need to do facilitated FHIR exchange as outlined in the QTF and in the facilitated FHIR SOP. We anticipate using the Vinci PDEX and CDEX IGs, and we would encourage them to implement use cases from the TEFCA treatment, payment, and also the healthcare operations exchange purposes. This is, oh, no, I'm sorry, next slide, please. So this is a representation of our ideal timeline, but this may need to be adjusted depending on the feedback we get from those wanting to participate. And as this timeline shows, we have already had a series of one-on-one conversations with most payers, but also some providers to gauge their interest. We also have had 2 kickoff meetings last week that were identical to each other just to accommodate the various schedules. And we are still in the recruitment phase, and we would like to find more entities that would be interested in participating. Next slide, please. So this is where I try to recruit you into the 10 by 10 project. And on this slide is kind of a checklist for participating within the 10 by 10 project. Ideally, anyone interested would be able to join TEFCA by the end of calendar year 2024. We are encouraging organizations that are interested to bring their own +1 along. And by +1, we mean, for example, if you're a payer, that we encourage you to identify your own provider or providers in whom you already or you have a need to exchange data with. And we also ask those who are interested is to review the QTF and the FHIR SOP to determine what the requirements are. And then they would have to update their capabilities in order to be able to participate. And so anyway, if you're interested in participating, you can reach out to Mark or me, or you can also contact Alex Contour, and his email is on this slide. And he's the one who's actually leading this effort within ASTP. And anyway, and he'll be able to help you. But any 3 of us you can contact. And so I'll go to the next slide. So this slide just provides some resources that are available. The first link is to the RCE, and that's where you can learn all about TEFCA, and you can read about the common agreement and the QTF and all the other resources that are there. And the second link is a link to ASTP's resources that we have on our website. And then at the bottom of the slide, there is a link to the RCE where you can register and attend their monthly informational calls about TEFCA. And those are open to everyone. And there are also recordings of past meetings that you can also review there. And then if we go to the last slide, this is really just our contact information, how you can get a hold of Mark and me, but also lists some of the social media and other ways to stay connected to ASTP. And that is the end of my remarks. Thank you very much. And I think I'll turn it over to Denise, and we'll probably launch into the question and answer session. So turn it over to Denise. Thank you.
Thank you, Chris, and thank you, Mark, so much really good information. And we've got questions, so not surprising. Folks are really interested. One in particular, which seems incredibly relevant to our Da Vinci community roundtable. So Chris, this may be for you, but could you talk a little bit about the difference between 10 by 10 and maybe its difference and or interplay between 10 by 10 and the Da Vinci Trebuchet FHIR pilots?
Yeah, absolutely. And for those of you that are maybe not familiar with Trebuchet, I'll start off by just providing a little bit of background and context. The word trebuchet, I think, is very interesting that it was named that, and whoever named this deserves like a bonus or something. But trebuchet is a type of medieval catapult, and it's a great metaphor for the project because one of the goals for the project is to come up with approaches for using FHIR API exchange to quickly get FHIR adoption into networks, including TEFCA. And additionally, they are focused on leveraging payer related use cases. And in fact, as many of you may know, and I think was just mentioned, that Da Vinci FHIR Accelerator is currently managing the project. But Trebuchet is similar to the 10 by 10 initiative in that it is focused on implementing FHIR exchange using payer-to-payer use cases. But in a sense, they're different than 10 by 10 in that Trebuchet is exploring FHIR implementation models in addition to the TEFCA facilitated FHIR approach. Also, they're starting by exchanging data outside of the TEFCA framework. But the idea is for Trebuchet to find methods for FHIR-based exchange to be quickly adopted, and then the TEFCA FHIR implementation advisor group, that group I was mentioning earlier, they will review and consider adopting those methods. And if adopted, the Trebuchet participants would be able to easily transition into TEFCA. The 10 by 10, on the other hand, will be implementing the TEFCA facilitated FHIR approach. And it's currently anticipated that it will be done within the TEFCA framework. But regardless, the interplay, now I'll talk about the interplay as opposed to the likenesses and differences. They're both focused on finding fast and efficient ways of adopting FHIR API exchange and using payer and provider use cases. And and while they're taking different approaches, we will be learning from both of them, and both of them, from their different perspectives and their different approaches, will help inform the way we implement FHIR into the future.
Excellent. Thank you so much. And obviously, it's an interesting synergy, a lot to learn. There's a lot going on. Looking at some of I think you actually answered one question a bit, but just to make sure, someone asked if the payment use cases were being supported currently, but it does sound like payment is included in the 10 by 10. Is that accurate?
Yeah, so the 10 by 10 is just getting going and launching. So we're not currently doing it, but yes, some payment and healthcare operations and even treatment will be some of the exchange purposes, and and the use cases within those exchange purposes will be analyzed and used in the 10 by 10 project.
Okay. And someone asks if any 10 by 10 participants have yet been identified. You did mention it's early in the process, so.
Yeah, so we've talked to a lot of people who are interested, and some will probably go forward, but it's still kind of early on, and they're still reviewing all the documentation and stuff, and so it's a process. It's a big commitment to do this, and we understand that, and so anyway, but yeah, there are some, particularly in the provider community, that are interested, and in the area that we're actually needing to spend more time on is in the payer community, and that's where that we're spending a lot of effort on right now, is recruiting in the payer community.
Good place to be talking to payers. Um, uh, are you mandating specific use cases for the full 10 by 10 to implement, or expecting each participant or pair of exchange partners to decide what they want to use it for?
Yeah, it's really the latter. It's really allowing the payer or provider and their plus one, we call them, really to decide for themselves. I mean, we're going to encourage them to to stay within healthcare operations or payment or treatment, of course. But really kind of let them kind of pick what will what's the thing that will get them to participate. What's that business case, the strongest business case that will enable them to participate? And that's what we're looking for.
Excellent. We got two related-ish questions. At least they cover the same topic. So I'll give you both and see if you think that create synergies where they may not exist. One is asking if you can speak to the differences between QHIN facilitated FHIR exchange and QHIN brokered FHIR exchange. And where we have related a bit here is a question you mentioned for the 10 by 10, that the IGs you're specifically calling out to start are some of the Vinci IGs. Particularly you called out, say, PDEX and CDEX. But there was a question about other IGs that are leveraged in the CMS and earlier, formerly ONC rules. the Care and Blue Button IG, but also the QHIN facilitated FHIR. So it seems we're having some synergistic questions around QHIN facilitated FHIR, how it relates to 10 by 10, the differences between QHIN facilitated FHIR exchange and QHIN brokered FHIR exchange. And so how does it all come together?
Yeah. Well, and you'll help me, you'll have to maybe help me keep track of it all because that was a lot to unpack there. But I'll start off with facilitated FHIR and then brokered FHIR exchange. So facilitated FHIR exchange, like I explained, it's really point-to-point exchange. It's one provider, for example, it's one provider really connecting to another provider, and then exchanging using the FHIR API exchange. Why we call it facilitated is because if a provider doesn't know who has information on the patient they're interested in, they can leverage the QHIN and the patient IHE patient discovery capabilities to identify who has that patient, and then also they can leverage the RCE directory, although they go through their QHIN to access it, but they'd be able to leverage the FHIR endpoints that are contained there to find out who they want to connect to. Brokered, on the other hand, is when it's that end-to-end, in the roadmap, and I talked about stage 4, it's really that end-to-end. So it's really, using FHIR API exchange, and the transactions are being routed through the network, but instead of using SOAP-based exchange, you're using RESTful-based exchange, basically. And so that's the difference between the two. And so then going to 10 by 10, 10 by 10 is leveraging the facilitated exchange because that's what we're supporting right now initially. And so that's the answer to that question. And then
I guess now that we know what the QHIN facilitated FHIR is, I think the question is about bringing in other IGs. And again, you mentioned the scope is still being defined.
Yeah, I mentioned PDEX and CDEX because those are the ones that, even if we weren't doing 10 by 10, they're the ones that we're encouraging the participants and sub-participants who are doing FHIR, we're encouraging them to support those. But having said that, yes, we are open for the 10 by 10 to use any of the implementation guides, and particularly those that are supported by CMS and the Vinci, the Vinci IGs. We're encouraging them to use those as appropriate, and following the CMS guidelines that they put out.
Okay. Thank you. So evaluating our questions here and seeing if you can pick a diversity. Always a good question. Could you share some real life examples of a participant using TEFCA and how that benefits their staff and or patients? So can you make TEFCA real for our participants today?
I'm going to let Mark take this one.
Yeah, so I mean, very open-ended, but I mean, if you think about who can be a participant, it's really any organization that signs, an agreement to connect the TEFCA with a TEFCA connector and includes the terms of participation. So, I mean, you look at a provider, I think, the benefits to joining TEFCA are, to me, pretty clear, that you're able to provide more complete care based on a complete medical record being at your disposal. You're able to provide coordinated care. So if, for example, sometimes we've heard, well, I have Epic, or I have Cerner, or some, my medical record. Well, if you go across the country and you're visiting, family on the other side of the country, and it's a different system, there's no guarantee that your records will be there, and the doctors won't have the records available necessarily at their disposal. So, I think from both a patient and a provider perspective, it's really just having a more complete record of the patient's medical history and being able to provide better care and care coordination. You look at public health, that's another one that's very important, obviously. and public health will be able to access information that they are not currently able to access, to understand what's going on. You know, with COVID, we all saw that the way the public health information is being exchanged from public health agencies and providers, it's not working the way it should, and there were a lot of issues. And TEFCA will hopefully shore up those gaps and enable public health information to benefit both the providers, but also obviously the patients in the country. Payers as well. I mean, as Chris has been talking about with healthcare operations and payment, and just noting that this is fresh in my mind because we're putting out some resources that focus specifically on the benefits for each of these groups. And there's some already available on the RC's website. You know, having information for like e-prior auth and things like that are not available right now are huge benefits. And again, it's not to say that the current exchanges and networks that are available aren't doing great things, and we're not trying to disrupt at all. We're trying to build on what you know, other networks have done already, but again, to make sure that there aren't gaps, and that when you want to access your information, you don't have to, as a patient, log into many different portals and remember different passwords and try to you know, have 10 different screens up at the same time to understand what your full medical record is. It all should be available in one place. I'm sure many on the call have heard the different analogies, but it's a lot like the cell phone industry. You know, like if you have Verizon, T-Mobile, doesn't matter. All of those agreements have been reached. And when you pick up the phone, your call goes through because all of the big companies who are essentially like QHINs have agreed to connect based on the same rules, and your call goes through. The same with your financial information. Like when you go to an ATM, they'll charge you a fee if you're not from that bank, but you're still able to access, you know, your account and pull money from your account. And that's just not the way it is with health IT right now. And so that's what we're trying to do big picture. And I think the benefits are for everyone in the country, really. Anyone who is a patient, a provider, a payer, you know, someone in public health, there's benefits for everyone.
Excellent, thank you. We've got a few questions that basically circle around a theme, which is, can I essentially engage in TEFCA simply wanting to use FHIR? Do I have to also be able to use IHE or SOAP? Can I really just go the TEFCA route purely on FHIR?
Yeah, so I'll take that one. So it depends on the QHIN that you use. One of the important things to understand about the QHINs and about TEFCA and the way we set up TEFCA, the IHE profiles are really aimed at the QHIN to QHIN exchange. So the exchange that happens between the two QHINs. How the QHINs operate within their own network is completely up to them. They have full autonomy to you know, to do the exchange however they would like to do it. And so you know, like a participant or a sub-participant signing up to TEFCA, you know, they could connect to their QHIN or to their participant or whoever they're connecting to using FHIR or you know, using any other method. But when you participate in participate in TEFCA, you know, you have to you know, follow the rules of the whole, you know, common agreement and the terms of participation. And so, yeah, you do have to follow all those things, but there are different ways in which that can happen.
Okay. Looking at our questions here. There was one related. Well, I guess we did a little bit of make TEFCA real, so now let's make 10 by 10 real for folks. Because there's a question of, could you summarize the reasons why a provider or payer and their +1 might want to sign up to be part of 10 by 10? What are the benefits of being an early adopter?
I'm sorry, I was on mute. Sorry about that. So anyway, that's a really good question. I appreciate that. I guess the best way to answer it is, talking about what we've heard from people who, because that's kind of where the road, we can, pontificate, but the kinds of things that we heard, why people want to. One reason is that participants in 10 by 10 will receive some help and support from a peer group to implement FHIR. Those that are participating in the 10 by 10, will work together and share lessons learned and best practices, and they can share the different challenges that they're able to overcome. And then additionally to that, they will gain, valuable experience in a safe and what I would consider anyway, low risk environment, where they will be able to initially be able to pick their FHIR exchange partner or partners, and then work out the kinks in their FHIR API exchange and TEFCA, and have that kind of experience, and that way they will be able to be better prepared when they will eventually be required to respond to the exchange purposes that have required responses, when you do FHIR. And then they will have an opportunity to be able to help influence the technology and the policies used in the TEFCA FHIR API exchange. And particularly, of course, those are related to healthcare operations and payment, those two exchange purposes. And, like I said, the TEFCA FHIR Advisor Group will analyze and consider the lessons learned from their experiences, but if you're participating, you'll be able to have that kind of an impact, influence, and of course, look after your own interests as well as how all this rolls forward.
You get to define the path if you get in there early. Always a good thing for being an early adopter. You mentioned the opportunity to enter at a low risk. You know exactly who your exchange partner is there. And we did get a question about TEFCA and risk. So the question we received was, how does ASTP and the RCE intend to prevent applications from working around exchange purposes via secondary use? So for an example, if an app pulls for treatment with the immediate intent to share it with a payer, life science company, or law firm. So the sort of the concern of what happens if there's that secondary use, and is there anything in play there to support that risk?
Yeah, I guess I can take that one, Chris. It's a great question. I mean, I think secondary use is a difficult thing, obviously, to keep in check. I mean, one thing specifically, the question was about apps. We do have a very strong notice of privacy practices that we require any apps, who are connecting to TEFCA to be very transparent, plain language about what they plan to do with the patient's information and how they plan to use it. Again, we're trying to create this balance between, freedom for a patient to get their information and do with it what they want, but also to make sure that they understand what these apps plan to do with it. I think, it's kind of related as far as, misuse of exchange. I think the Epic Particle Health situation that I think many folks are aware of brought to light that there is some trust that's been eroded within health information exchange. And, I think, I'm not sure how much folks have heard, but ONC is trying to take a different approach with our treatment exchange under TEFCA, and we're trying to, create different levels. We're still working on the specific framework, but to step back a minute and understand what are the use cases that everyone agrees, or, most people agree are allowable for treatment purposes, and creating new kind of definitions that are specific to TEFCA-based exchange, and then trying to build out the required response over time to make sure that that trust is there. Because starting with a very broad definition and not everyone understanding how that, what that means is not great for the overall trust for interoperability nationwide. So, I mean, I think that's two pieces that are related, but overall, TEFCA is extremely concerned about making sure that everyone is trusting the exchange that's going on, and we are doing everything we can to limit risk. One other thing just to highlight again is that we do make sure that TEFCA works within the confines of applicable law. we incorporate the HIPAA security rule and the HIPAA privacy rule in many ways, and extend it to non-HIPAA entities, like I mentioned before. So I think there's a lot of protections in place that really make TEFCA an appealing place to exchange information.
Thank you, and thank you both so much. You've answered a ton of questions, and we could probably go all evening with some questions, but I'm going to end with one, so we can let you stop talking for a few. I've made you keep going, but we're really thankful, and we're really thankful for everyone's engagement, because there's clearly a lot more for us to talk about, and we'll be really excited to continue to work together as ASTP gets more engaged in officially in the Da Vinci project, and we engage on supporting everyone in a successful 10 by 10 program. So one of the questions was really about the definition of provider, perhaps, for that +1. Can a payer bring a vendor partner to be or does it have to be a more specific definition of provider as a user of a vendor product?
Yeah, we would have to take a look at, what it is, what they were, wanting to do. I mean, it has to, we're exchanging data, under the exchange purposes of the, common agreement, and so we just have to, see what, what that looks like. But we're very open. We're looking for people who are, or, we're looking for it's a coalition of the willing, is what we like to say, and so, we'll definitely take a look at, look at that, it's not it's not an absolute no or anything like that. We'll just take a look.
Okay, so I think the moral of the story is, if you're at all interested, reach out.
Exactly.
You have both Chris and Mark's emails. You have Alex's email as well in the presentation materials. Do reach out with questions on engaging in 10 by 10. And we're very excited as Da Vinci to have ASTP getting more and more involved, and we'll be really excited to see that interplay between Trebuchet and 10 by 10. So again, Chris, Mark, thank you so much. I do want to take a few minutes and make sure we can get through our last topic today. So we will switch gears here for a minute and give you a quick overview of what the Da Vinci community has been up to. So we have collectively been taking a look at HTI-2. So if we go to the next slide, as many of you are very well aware, the health data technology and interoperability, patient engagement, information sharing, and public health interoperability, or much easier to say, HTI-2 proposed rule, is officially out for public comment. Public comments are due October 4th by 5 p.m. Eastern, and the link to the Federal Register is on the slide. And this is the latest proposed rule coming out from ASTP to support a number of different pieces of the puzzle, some of which are incredibly relevant to the work that we do in Da Vinci. So there are new health IT certification requirements for public health and payers. So something that we're paying close attention to. HTI-2 builds on the interoperability and technology standards that were finalized in HTI-1. And it takes us from the US core data for interoperability from V2 to V4, which would be for those who have strong requirements, and there's a lot of nuance in dates as you're paying close attention to all things HTI-2, but officially it would bring US CDI V4 into play on January 1, 2028. And there's a lot in there also on information blocking and TEFCA, particularly TEFCA on FHIR. So for those interested, do take a look at that. From the Da Vinci perspective, if we go to the next slide, what we've been doing is taking a close look at the topics. And I think actually if you go to the previous slide, thank you. We've been looking specifically at the topics in HTI-2 that very directly impact the work that we do in Da Vinci. And as we often do when a RFI or proposed rule comes out, that relates significantly to the work that we're doing, we'll get members together, hold a series of consensus sessions, and work to produce our comment letter to share back on that FHIR proposed rule. So that's what we're doing now. We're meeting on Thursday afternoons, and we're talking through the issues that are raised within HTI-2 that are very relevant to our work in Da Vinci to define what our consensus response will be to the proposed rule. So there are 5 new criterion that really jumped out as very, very relevant to what we are doing in the Da Vinci world. And these are new health IT certification criteria that apply to payers and providers, and that are directly related, obviously, to the CMS regulations that we've also talked a great deal about as a community. And these are criterion related to the Patient Access API, Provider Access API, Payer-to-Payer API, Provider Directory API, and the Prior Authorization API. And so you see direct synergy here with the CMS requirements. And you will see a number of Da Vinci implementation guides specifically noted. And one of the real primary points of conversation has been around this piece, because as you will see, the HTI-2 proposed rule specifically proposes to require these specific versions of each of the IGs to support each of the API certification criterion. And there's a lot of detail in the rule. There are, which pieces of this puzzle specifically refer to or are specifically relevant to a provider, which are specifically relevant to a payer. And that is an important nuance. And then there's also some good information around sort of, if, for instance, PDEX, which is currently out in version 2.0, STU2, is currently going through balloting. And if the balloted version, 2.1, is available prior to the final rule being published, that is the version that would be named in the final rule. So lots of details to check out, but one of the really important things for the Da Vinci project is to sort of look at all of this and decide, what do we think? What do we think is the important pieces of information to share with ASTP as they are looking through comments and ultimately finalizing this rule? So on the next slide, we talk a little bit about really where we've been focusing. And we've been focused on the importance of focusing on FHIR. So there's a general consensus and support for so many of the new criteria really looking at FHIR-based exchanges and really making it clear and sending a clear message that FHIR is where we're going, which is very consistent with everything else that we've seen. So it's a very positive thing. We've had a lot of conversation about required versus recommended IG versions. Both the opportunities and challenges associated with a required version. As we all know, the CMS rules to date have recommended strongly the use of specific IGs to facilitate, say, all of these APIs that these certification criteria relate to. And in the ONC proposed rule, ASTP, HTI-2, the proposal is to require those specific IG versions. And the community is currently having a very deep conversation, and that conversation continues about the benefits and challenges of required versus recommended. The proposed rule does state that as a specific version is required in the rule, that the later versions can come into play through the standard version advancement process through SBAP, the same process used today for US CDI that you're all very familiar with. So there is that opportunity to continue to iterate on a required version, but it does in fact name the specific version for the initial proposals. So that's something we're really working through now, and there's a lot of great conversations still going on this point, and something we're looking to continue as we work to come to consensus as Da Vinci around our response to that item. We've had a lot of conversation about the synergy between the CMS rules and the requirements across actors. This is something Da Vinci has previously been vocal about, and it's, as we indicated actually in our RFI response when ASTP released an RFI about a potential prior authorization certification criterion. And we were looking at really sort of the early stages of what now is the prior authorization API proposal. We did note that it's so important to have the requirements on both sides. So obviously the CMS rules are very much focused on the payer side, for those payers who are regulated by CMS. And there is, some on the provider side in terms of, say, for instance, the opportunity within some CMS measures programs to also engage on the prior authorization side. But this would be one way in a certification criterion to really have both sides of the equation of, say, a prior authorization or a payer to provider data exchange really be held to the same standards and have the same motivations to move these exchanges forward. And I will also note that similarly, folks have noted that these regulations to date really have helped push interoperability forward, even the recommended IGs, and so really appreciating the opportunity to continue to push the interoperability forward and really push the industry forward through these regulations. We're also talking about the new concept of a certified health IT for payers, and what does that mean? Because for some payers, it really is sort of internal systems kind of cobbled together, and for others, it's leveraging vendors, and for others, it's sort of very clear, dedicated systems for a particular type of exchange. So really just thinking through that and understanding what certification could mean. Of course, appreciating that in the proposed rule, and to start, any certification of payer health IT is purely voluntary at this time and not, tied to any other specific programs at the moment. What we will say is join the discussion. For Da Vinci members who are listening in today, we want to hear your voice. We have at least a couple more discussions coming. So this Thursday, tomorrow at 4 o'clock, 4 to 5:30 Eastern, you can join us for the discussion if you're a Da Vinci member next Thursday as well. So please don't hesitate. You can reach out to me. My email address is on the slide, and I'll make sure you have the information to join the conversation tomorrow and next week, and or contribute via email or any other way you can share with us your thoughts on these really important topics that we're really excited to continue to iterate on. So with that, that's where we are today in our Da Vinci review of HTI-2. More to come as the community continues to discuss these really important and exciting proposals. So I will take a quick look. There are new provider certifications as well. There's lots in the rule. Looking at the question box, and it's just jam-packed. So do not wait if you haven't already started reading. Get there and read. And again, we are in the Da Vinci project, in the interest of time, sort of focusing our attention on some specific pieces that are very much payer related. But we do encourage you, please join. All right. Well, I am not seeing any other questions, and we are a few minutes to the end here. I will note that we are looking again at our next community roundtable to be in October, skipping September, as we will see everyone in Atlanta for the HL7 work group meeting in September, and we'll reconvene on the Da Vinci Community Roundtable at the end of October on October 23rd. I really cannot thank Mark and Chris enough for their insights and for all the great information on TEFCA and 10 by 10. Everyone do reach out. ask all your questions, get engaged in 10 by 10, and we will be very excited to follow that journey as it evolves. So again, huge thank you, Mark and Chris, and a huge thank you to Leslie for all of her work helping us get this content out to you today. And finally, a big thank you all for joining us today. So do please take a moment, fill out the survey before you log off for good today. That will pop up once you exit the webinar. And we look forward to seeing you in October. So thank you all so much.